This recording is part 2 of the Midas Mission 2.0 seminar meeting held on November 11th, 2015. It is a continuation of the seminar given by Dr. Samuel Scarpino on the topic of disease surveillance in lower socioeconomic populations. To become a member of Mission 2.0 and stay informed about all our activities and events, send an email to the address listed at the bottom of the screen.
We then transitioned, and this is work done in collaboration with Lauren Myers, Ned Dimitrov, James Scott, Roz Ego, and the Texas Department of State Health Services to try to understand poverty and influenza in Dallas, Texas. So we're looking at a similar map for the Dallas-Fort Worth area of Texas. Again, this is in sort of the northeastern corner of Texas. And again, we're looking at 5 counties, and I've colored the zip codes by proportion in poverty, ranging from 0 to about 50% of the zip code below poverty. And we have a similar finding to what most people have discovered when they look at the relationship between poverty and disease, is that in poorer areas, you have higher disease rates. So on the x-axis, we have the percent of the population in a zip code below poverty. Each dot is a zip code in the Dallas-Fort Worth area. And on the y-axis, we have the influenza hospitalization rate per 1,000. And you can see that there's a significant positive relationship. Poorer zip codes have higher hospitalization rates. And interestingly enough, we can't explain this difference, this higher rate of hospitalizations, just based on differences in age distribution. So we know there are higher hospitalization rates in the over 65 age group, and those differences can't explain this relationship. So there's something else that's going on with poverty. So what we're going to try to do is to predict inpatient hospitalizations for laboratory-confirmed influenza along a socioeconomic gradient in the Dallas-Fort Worth area. In particular, we're going to bin zip codes into poverty quartiles. So we'll have the wealthiest quartile, the quartile with the fewest people below poverty, the middle upper, the middle lower, and the lower quartile. And so what we're looking at here is that this is the time series that we're going to try to predict in the poorest quartile. So these are zip codes with greater than 21.5% of their population in poverty. And I should say that I also controlled for population size. So these quartiles have the same number of people living in all of them. So you can see from 2007 to 2012 that we have peaks in the winter like we would expect for flu, but it's a fairly sparse time series. The largest outbreak was the 2009 pandemic fall wave, with about 35 inpatient hospitalizations in any given week. So each dot is a week. We can look in the richest quartile, and immediately you can see this effect, right? So these are, again, the same time period in 2007 to 2012, the number of laboratory-confirmed inpatient hospitalizations, and approximately the same number of people live in these zip codes as live in these zip codes. But you can notice that the peaks here are occurring around 10 or 20, as opposed to around 20 to 40. So almost a factor of 2 lower for these zip codes. So what we're going to do is we're going to use data from the influenza-like illness network providers. So these are primary healthcare providers that report weekly to the state of Texas and the CDC based on a case symptomatic definition for flu, so no laboratory tests. We're going to use data from emergency departments. These are in the BioSense 2.0 surveillance system. So we'll have data on upper respiratory infections that were identified as the chief complaint coming into emergency departments in the Dallas-Fort Worth area. And then we'll also have data from Google Flu Trends. And we're going to use these data sets to try to make 2-week ahead predictions of inpatient hospitalizations. I should also mention that one of the things that happens is we take the ILINET data, which is at the zip code level. We take the BioSense emergency department data at the zip code level. We take the Google Flu Trends data, which is at the city level and state level. We do a series of nonlinear transformations, and then we take the first and second differences, so the discrete form of the velocity and acceleration, and we're going to use all of these as potential predictors. So we end up with about 200 potential predictors. And then what we'll do is we'll use Poisson regression with some regularization that looks like basically a combination between a lasso and a ridge penalty with cross-validation to pare down the number of predictors. So we end up with, from about 150 or so predictors in each model, about 6 or 7 predictors with coefficients that are greater than 0. And we'll have separate models for each poverty quartile. This is just showing you the aggregate time series of the data sets we're using. So influenza-associated hospitalizations on the top. And again, we've aggregated all the quartiles here. The influenza-like illness data, the Biosense upper respiratory infection data, and the Google flu trends data. And of course, you'll notice on the Biosense upper respiratory infection that it's a lot noisier and looks a lot less like flu, especially outside of the peaks. And that's because these are all chief complaints associated with upper respiratory infection. So we expect it to be a lot less specific with respect to influenza. So it turns out for the richest upper middle and lower middle quartiles, we can do a fairly good job of predicting these time series, even though they're very sparse. So what we're looking at, again, the gray dots are the observed data. The blue line are our 2-week ahead predictions for each of the gray dots. And you'll notice that the blue line, for the most part, is right on top of the gray dots. We actually get fairly accurate 2-week ahead forecasts on the number of inpatient hospitalizations that are going to occur in these 3 quartiles. However, the same is not true for predicting hospitalizations in the poorest quartile. So what we're looking at here are the fits to the poorest quartile, those with greater than 21.5% in poverty. Again, the black dots are the weekly number of hospitalizations, and the red curve is the fitted model. And you'll see that we often underpredict the peak in the first 2 seasons. We overpredict the peak in the next 2 seasons. We underpredict by a substantial factor the 2009 pandemic fall wave. And then we actually do a fairly good job in 2011 of predicting the peak. Using both the log likelihoods on the cross-validation and the root mean squared error on the cross-validation, these fits are significantly worse than any of the other 3 poverty quartiles. And the way that we tested this is we basically randomized the number of individuals in each below poverty in each zip code. So we basically reassign the number of individuals below the poverty line in each zip code. We basically shuffle the ordering. We rebuild the quartiles based on these new shuffled poverty quartiles. We refit models to each of the 4 quartiles. And then we look at the maximum difference between the best fit and the worst fit models based on this out-of-sample log likelihood and this out-of-sample root mean squared error, and we generate a distribution of these differences between the best fit and the worst fit model. And then we compare the fit to the poorest quartile to the fit to the richest quartile. This is comparing empirically the best and the worst fit models. And it turns out, as I mentioned, both for the out-of-sample log likelihood and for the out-of-sample root mean squared error, we do significantly worse at predicting these hospitalizations. So one thought that occurred to us is perhaps this is an artifact. Perhaps what we've done is we've aggregated 4 zip codes together that are out of phase with each other. So we've aggregated urban poor and rural poor, and the urban and rural areas are just out of sync. And so there's some sort of statistical issue with the prediction. Well, this turns out not to be the case, and it actually turns out to recapitulate some of the results from El Paso. Namely, we find that the poorest zip codes are actually more in sync with each other. So one of the ways we looked at this was for each poverty quartile, we can calculate the pairwise correlation between the time series of each zip code in that quartile. And that's what's plotted here. So we have blue, the richest, light blue, the upper middle, orange, the lower middle, and red, the poorest quartile. Box whisker plots of the pairwise correlations, and you can see them creeping up as we go from richer to poorer. And it turns out by similar permutation tests, the poorest 25% of zip codes are significantly more correlated with each other than are the richest zip codes. We also confirmed these results or got results that support this conclusion using a principal component analysis. So it turns out that the first axis of variation explains significantly more of the variation in the poverty quartile, the poorest poverty quartile group, than it does in any of the richer quartile groups. So if you think about this prediction result from a statistical perspective, we have both a richer time series, so this time series in the poorest quartile is less sparse than this time series in the richest quartile, and we have an aggregate time series in the poorest quartile that comes from zip codes that are more in sync with each other. So from a purely statistical perspective, we should be able to do a better job of predicting this time series than this time series. And we see the opposite. And we, of course, hypothesize that's because these individuals in the poorest poverty quartile have reduced access to healthcare. And so they're not touching these surveillance data sets that we're seeing. They're not going to the ILNet providers. They're not interacting with Google in the same way, or they're not using Google at all. And perhaps a little bit surprisingly, they're not using the emergency departments for upper respiratory infections. Now, a couple of points to make about the emergency departments. We have data from 70% of the emergency departments in the Dallas-Fort Worth area, so we don't have an exhaustive sample. That's one caveat. Another caveat is probably the obvious one, which is that we don't have the flu time series from Biosense. We just have the upper respiratory infection time series. So maybe with a more specific time series, we would improve. However, what I will say is that about a third of inpatient hospitalizations for flu in Texas bypass the emergency department entirely and are directly admitted to inpatient. So it's not entirely out of the question that these individuals from the most impoverished zip codes are in fact not touching these public health surveillance data sets at all. And if we put this in the context of this flow diagram that I started this part of the talk with, this path analysis from Shi et al., we know that there's a reduced life expectancy that's indirectly mediated by reduced access to primary health care. But what we've identified here is that there's also public health consequences in terms of impaired situational awareness because these individuals are not interacting with our surveillance data streams, which I think is as yet an overlooked effect of reduced access to healthcare in more impoverished areas. A second thing is that if we tried to predict just the aggregate time series of influenza hospitalizations, we actually do a poor job of doing it. In fact, it's basically a weighted average of our performance in each of the four poverty quartiles. So this gets back to one of the things that's come up in the Midas group a number of times over the years, is that working with aggregate data can be a big challenge. And one of the reasons is that the mechanisms driving these infectious processes can vary both spatially and socially, such that you really can never come up with a single model that can accurately forecast or predict some of these aggregate time series. And we really need to drill down and try to make predictions at very local levels that accurately account for differences along socioeconomic gradients, differences along geopolitical gradients. Real quick, I'll end by making a plug for where I'm headed next. I'm starting an assistant professorship at the University of Vermont in the Mathematics and Statistics Department in January. I'll also be a part of their Complex Systems Center. Starting this fall, we actually began offering a master's in complex systems and data science through the Complex Systems Center. So if that sounds like something that you or someone else may be interested in, please get in touch with me. I'm also, as most people starting a new assistant professorship position, I'm looking for potential graduate students and postdocs. So if you're thinking about surveillance or prediction, please get in touch with me. I'd like to acknowledge all the people that work with me on this project. So as I mentioned, James, Ned, Roz, and Lauren worked with me in the Texas Department of State Health Services on the Dallas-Fort Worth part of the work. Alejandra and Fernando are with the City of El Paso Health Department. Fernando Gonzalez is the chief epidemiologist for the City of El Paso. They worked with me on the El Paso part of the project. Mike Johansson and I worked with Lauren Myers on the dengue project, and then funding from NIH Midas, the Santa Fe Institute, and the Omidyar Group. And with that, I am very happy to take any of your questions. And again, thank you very much for having me and for listening to the presentation. Thanks.
Awesome. Thank you, Sam, and congratulations on your new position. I'm sure that you'll be very successful at it, no doubt about that. Are there any questions from the audience?
Hey, Sam, this is Brian over at the VBI group. Sorry, maybe I missed it, but I was wondering if you could go back to the hospitalization predictions And so you were able to get by zip code hospitalization records, I'm guessing, from collaborating with this group. I guess my question comes down to, when you were doing the selection for the models that were predicting, you alluded to it. I don't know if I caught the full list of what the top 6, 7 predictors in the models ended up being, even though they weren't necessarily doing the best job. You said something about Google Flu Trends. I was just curious about what the other ones might have been in there.
Yeah, so it's a good question, Brian. So the question is, what predictors ended up being included in the models? And I actually don't remember what they are off the top of my head, because it wasn't really as though there was an obvious set of results that you might have sort of guessed ahead of time. And of course, like, this is one of the issues with, these sort of slightly more black box approaches, like the one that we use for selecting the predictors. But what I can say is that we had data from emergency departments, so from BioSense, we had data from ILINet and data from Google Flu Trends. And the best fit models included some predictors from each of those data sets. So it wasn't the case that we could do better with just ILINet alone, or just Google Flu Trends alone, or just BioSense alone. There's some degree of complementarity in those data sets such that we could do better by selecting some predictors from each of those sets. One of the things I mentioned, that we had these sort of discrete form of the velocity and acceleration, those were almost really never picked. We actually thought maybe that would be useful, because hospitalizations tend to peak a little bit later than ILINet and Google Flu Trends, and even to a certain extent BioSense. So we thought maybe these acceleration or velocity terms would be useful, and they really weren't ever selected by any of the models.
No, that's strange. I was expecting some of those to show up, so okay, that's useful to know.
No, we did, yeah. And again, I mean, obviously this is just the results for what we got here in Texas. So it would be really cool to see what this looks like in other locations, whether this is just something peculiar here about the data we have, or whether it's a more general phenomenon that at least our working assumption about the utility of these sort of velocity or acceleration things is wrong, basically.
Okay, we have a question over here at the PSC from Jenny.
Yes, I was wondering if you looked at age at all. And the reason I'm saying this is there's no question poverty has huge impacts on health. However, in addition, families that lower income rates have higher birth rates. And so 2 possibilities for differences as far as influenza in areas that are poorer are both the population density, i.e. how close we are so that we're transmitting it, and also the number of children. And for 2009, this is particularly important because people who were born before June of 1958 had some immunity to H1N1, which is the reason that if you look at the regular mortality rates, 2009 doesn't look like it was big, but if you look at mortality in children, it's off the scale. So did you look at age and population density at all?
Yeah, so both very good questions. So the questions are potential effects of age and potential effects of population density. So I'll answer the population density question first, which is we know, at least in the urban areas in Dallas-Fort Worth, the densities are higher. We assume, probably comparing rural areas to rural areas, the densities are going to be higher in poor areas as well. That's not something that we explicitly included. So that would be a useful thing to follow up on, because of course, from a social network perspective, as you alluded to, denser connections are going to change some of your expectations about the potential number of infections, the total outbreak size. In terms of age, we do find higher rates of hospitalizations across the whole time series in older age groups. We can't explain the higher hospitalization rate in older age groups. We can't explain the higher hospitalization rate in poor zip codes by more people over 65 in those zip codes. What we didn't do, and it's a very good suggestion, we didn't ask whether, in this case, some of our failed predictions during the 2009 pandemic in the poorest zip codes were due to differences in age distributions that map on to differences in hospitalization rates by age group that occurred during the 2009 pandemic. So we didn't look at that, and that's a good suggestion. What I can say, the one thing we did find that very much matches with your expectations, in El Paso, we do see higher rates of influenza in poor zip codes, and it's primarily driven by higher positive tests for influenza B, and we do see substantially higher numbers of individuals in younger age groups in these poor zip codes, and that of course would match with at least my understanding of where flu B is likely to end up being most severe. So in the El Paso study, we definitely see an effect of age that matches up with what you suggested. For the Dallas study, we didn't look at it exactly the way that you described, and that's a very good suggestion.
Thank you.
Great. Any other questions from anyone from the audience? No? Okay, well, great. Well, thank you. There's something in the chat window?
Oh, I can't see the chat window. Maybe if I unshare my screen,
we're checking it now.
Okay. Oh, chat. Here we go. Oh, I can see it now. All right. This is from. Oh, I can't see it anymore.
It's from Roni. What would
okay.
Roni Rosenthal?
Oh, here it is. Yeah. Oh, go ahead. Sorry, Sean.
What would the typical path of the poor to get hospital? What would be the typical path of the poor to get hospitalized if they do not seem to pass through an office visit nor through the ED?
Yeah, so very good question. I won't repeat it because Sean just read it out loud. But if anyone didn't hear the question, it's in the chat window. So we don't know is the answer, right? So as I mentioned, we don't have all the emergency departments in the Dallas-Fort Worth area. We have about 70%. We also don't have all the primary healthcare providers because ILI-Net, of course, is just a small sample of primary healthcare providers. So one possible explanation is that we don't have the right providers in our data set, right? And of course, there's no way we can really know that without doing a detailed study on individuals that are being hospitalized to find out what they did before they came through the door to get hospitalized. As I mentioned, we know that in Texas, something like a third of hospitalizations, inpatient hospitalizations, don't actually go through the emergency department. I don't exactly know how that works, but I think you can show up at triage and just be admitted directly to inpatient and not actually go through the emergency department at all. So one possible explanation is that that's happening pretty prevalently in these poor zip codes. It's one of the things that we very much want to follow up on, but I think it's going to require, a really detailed study where we try to, maybe even effectively interview people to find out where they went before they came into the hospital, or work with a network that actually has the ability to track patients to see, where were they first diagnosed with something, where did they go next, where did they go next. And aside from either of those two, I really don't have any ideas about how to get at that question because I think it's a good one and it's probably the most obvious, question mark surrounding our results with poverty. So certainly, if anyone has any thoughts, I'd love to hear them now or later offline. But
okay, Roni, any follow up to that, or that was good? Okay, there we go. Nope, good. That was good. Thanks from Roni. Okay. Any other questions from the audience? Okay, with no questions coming through, I'd like to once again thank Sam for taking the time to speak with us. It was a really, really nice presentation, some great work. And again, Sam, congratulations on the new professorship. We expect great things from you.
Well, thank you very much. It was a real pleasure talking with everyone, and enjoy the rest of the week.